Ventral wall hernias. Q&A, a comprehensive question and answer guide. Welcome to our in-depth podcast episode exploring the essential knowledge all general surgery residents should have on the management of ventral wall hernias. In this session, we will go through 100 commonly asked questions, each followed by a clear, detailed answer. Pause the video when you hear the word answer to attempt questions. Let's get started. Anatomy, classification, and diagnosis. Question: what is a ventral hernia? Answer: a ventral hernia is a protrusion through the anterior abdominal wall, excluding the inguinal region. This encompasses umbilical, epigastric, spigelian, incisional, and primary lumbar hernias. Question: what is the difference between a direct and an indirect hernia? Answer: this terminology is specific to inguinal hernias. For ventral hernias, we describe them according to their location and whether they are primary or incisional. Question: what is an incisional hernia? Answer: an incisional hernia is a ventral hernia that develops through a prior surgical incision, representing a complication of wound healing. Question: what is the approximate incidence of incisional hernia after laparotomy? Answer: the incidence is approximately 10 to 15% but can be significantly higher in patients with increased risk factors. Question: what are the borders of the spigelian fascia? Answer: the spigelian fascia is bordered by the lateral edge of the rectus sheath, lineus semilunaris, medially, the transversus abdominis muscle laterally, and the arcuate line inferiorly. A spigelian hernia occurs through this fascial plane. Question: what is a Richter's hernia? Answer: a Richter's hernia is one in which only the antimesenteric border of the bowel is trapped in the hernia sac. The bowel lumen may remain patent, but the trapped segment can become strangulated and perforate without causing obstruction. Question: what is a Letra's hernia? Answer: a Letra's hernia contains a Meckel's diverticulum. Question: what is an Amyans hernia? Answer: an Amyans hernia is one that contains the appendix. Question: how do you classify ventral hernias by size? Answer: small hernias are less than 2 centimeters, medium hernias are 2 to 4 centimeters, large hernias are greater than 4 centimeters up to 10 centimeters, and giant hernias are those greater than 10 centimeters. Question: what is the European Hernia Society classification? Answer: this classification describes hernias by location. Midline: M. Subxiphoid. M1. Epigastric. M2. Umbilical. M3. Infraumbilical. M4. Suprapubic. M5. Lateral. L. And size: W1. Less than 4 centimeters. W2. 4 to 10 centimeters. W3. Greater than 10 centimeters. Question: what is the ventral hernia working group grade? Answer: this is a risk stratification system for surgical site occurrences. Grade 1, low risk, no comorbidities. Grade 2, comorbid, such as smoking, obesity, diabetes, or immunosuppression. Grade 3, potentially contaminated, including previous wound infection, stoma, or violation of the gastrointestinal tract. Grade 4, infected, such as infected mesh or septic dehiscence. Question: what is a loss of domain hernia? Answer: this term refers to a giant hernia where a significant portion of abdominal contents has resided outside the abdominal cavity for an extended period, resulting in a reduced abdominal capacity and potential danger of respiratory compromise or abdominal compartment syndrome upon reduction. Question: what is the calculated volume ratio? Answer: the calculated volume ratio is a computed tomography-based measurement to quantify loss of domain, defined as hernia sac volume divided by the total of abdominal cavity volume plus hernia sac volume. A ratio greater than 20% is significant, and greater than 30% is associated with a high risk of complications after reduction. Question: how is a ventral hernia typically diagnosed? Answer: diagnosis is primarily by physical examination, looking for a visible, often reducible bulge with a palpable defect. Imaging is used in complex cases, obese patients, or when hernias are painful. Question: what is the best imaging study for a ventral hernia? Answer: a computed tomography scan with intravenous contrast is preferred, as it defines size, location, contents, and aids in preoperative planning and measurement of loss of domain. Question: what is the role of ultrasound? Answer: ultrasound is useful for dynamic evaluation in thin patients, for differentiating a hernia from a lipoma, or confirming reducibility. Preoperative planning and optimization. Question: what is the most important modifiable risk factor for hernia recurrence? Answer: Smoking is the most important modifiable risk factor. Patients are encouraged to quit for at least 4 weeks before surgery. Question: what is the goal body mass index for elective ventral hernia repair? Answer: ideally, the body mass index should be under 35 kilograms per square meter, preferably less than 30 kilograms per square meter, to reduce recurrence and infection risk. Question: why is diabetes optimization important? Answer: glycated hemoglobin should be optimized to less than 7 to 8% to reduce the risk of surgical site infection. Question: what nutritional markers are important? Answer: albumin should be above 3 grams per deciliter and prealbumin above 15 milligrams per deciliter, as malnutrition impairs wound healing. Question: what is the role of prehabilitation? Answer: preoperative physical therapy and incentive spirometry are recommended, especially for large hernias, to strengthen the core and improve respiratory function. Question: when is bowel preparation indicated? Answer: bowel preparation is considered when entry into the peritoneal cavity is likely or in potentially contaminated cases. Question: what is the role of botulinum toxin A preoperatively? Answer: injected into the lateral abdominal wall 2 to 4 weeks before surgery for large hernias with loss of domain. Botulinum toxin A flaccidly relaxes the muscles, facilitating fascial closure without tension. Question: what is progressive preoperative pneumoperitoneum? Answer: this is a historical technique involving insufflation of air into the peritoneal cavity over days or weeks to stretch the abdominal wall for giant hernias. It has largely been replaced by botulinum toxin. Question: when is a hernia considered incarcerated? Answer: a hernia is incarcerated when its contents cannot be reduced back into the abdominal cavity. Question: when is a hernia considered strangulated? Answer: strangulation refers to compromised blood supply to the hernia contents, leading to ischemia. This is a surgical emergency. Question: what are the signs of strangulation? Answer: a painful, tender, non-reducible hernia with signs of obstruction, overlying skin changes, and systemic signs like fever or sepsis may indicate strangulation. Question: what is the first step in managing an acutely incarcerated hernia? Answer: a gentle attempt at manual reduction should be made if there are no signs of strangulation, with sedation used to facilitate reduction. Question: when should you not attempt reduction? Answer: reduction should not be attempted if there are signs of strangulation or peritonitis. These cases require emergent operative exploration. Operative repair, principles and techniques. Question: what are the 3 general types of hernia repair? Answer: the types are primary tissue repair via suturing fascia, bioprosthetic mesh repair using biologic or biosynthetic mesh, and synthetic mesh repair with permanent synthetic materials. Question: why is primary repair without mesh falling out of favor? Answer: primary suture repairs have very high recurrence rates, up to 50% for incisional hernias, and are generally reserved for small, clean, primary defects. Question: what are the main positions for mesh placement? Answer: mesh can be placed as an onlay, over the anterior fascia, inlay, sutured to the edges of the defect, sublay, retrorectus or preperitoneal, or underlay, intraperitoneal. Question: what is the Rives stopper repair? Answer: it is a classic sublay technique where mesh is placed in the retrorectus space, behind the rectus muscle but anterior to the posterior sheath. Question: what is the most important principle of mesh repair? Answer: achieving a tension-free closure of the midline and ensuring a wide mesh overlap of at least 3 to 5 centimeters in all directions. Question: what are the types of mesh? Answer: options include synthetic meshes, permanent, polypropylene, polyester, expanded polytetrafluoroethylene, resorbable, polyglactin, biological meshes derived from human or animal tissue, and biosynthetic meshes that are long, lasting absorbable materials. Question: when do you use synthetic mesh? Answer: synthetic mesh is preferred in clean cases, specifically in ventral hernia working group grades 1 and 2, due to its durability and low recurrence rate. Question: when do you use biologic mesh? Answer: biologic mesh is used in contaminated or dirty fields where the risk of infection is high and permanent foreign material is contraindicated. Question: what is a component separation technique? Answer: this procedure releases the external oblique, internal oblique, and transversus abdominis muscles from their fascia, allowing medial advancement of the rectus muscles for tension-free closure. Question: what is a posterior component separation? also known as transversus abdominis release? Answer. Transversus abdominis release involves dividing the transversus abdominis muscle to enter the retromuscular space and create a large plane for sublime mesh, often extending from the diaphragm to the pubis. Question. What are the advantages of the transversus abdominis release procedure? Answer. It allows significant medial flap advancement, optimal sublime mesh placement, and avoids subcutaneous dissection, reducing the risk of seroma. Question. What is the laparoscopic intraperitoneal online mesh technique? Answer. This minimally invasive approach involves placing mesh inside the peritoneal cavity against the abdominal wall, using a barrier-coated mesh to prevent adhesions. Question. What are the advantages of laparoscopic intraperitoneal online mesh? Answer. Advantages include faster recovery, reduced wound morbidity, and less post-operative pain in suitable patients. Question. What are the disadvantages of laparoscopic intraperitoneal online mesh? Answer. Disadvantages include a higher risk of adhesiolysis injuries, seroma formation, chronic pain, and the inability to perform component separation. Question. What is the robotic approach to ventral hernia repair? Answer. The robotic technique allows for minimally invasive surgery with the technical advantages of sublime or transversus abdominis release repairs, combining the benefits of laparoscopy with optimal mesh positioning. Question. How do you choose between open, laparoscopic, and robotic repair? Answer. Selection depends on hernia size, patient factors, surgeon expertise, and contamination status. Small hernias are often approached laparoscopic, while large or complex hernias may require open or robotic sublime or transversus abdominis release repair. Contaminated cases typically undergo open repair with biologic mesh. Question. What is the key step in any laparoscopic hernia repair? Answer. Adhesiolysis is essential to reduce hernia contents and clearly define the defect's edges. Question. How is mesh fixed laparoscopic? Answer. Mesh is secured with a combination of transfascial sutures, which are most important for preventing recurrence, and tackers for apposition. Question. What is a hybrid approach? Answer. The hybrid technique combines laparoscopic adhesiolysis with a small open incision for mesh placement or fascial closure. Question. How do you manage the hernia sac during laparoscopic repair? Answer. The sac is typically left in place, as reducing the entire sac can create a large dead space and increase the risk of seroma formation. Question. What is a seroma and why is it common? Answer. A seroma is a fluid collection in the space where the hernia sac was located, commonly occurring because the peritoneum has not yet readhered to the abdominal wall. Post-operative management and complications. Question. What is the most common complication after ventral hernia repair? Answer. Seroma formation is the most frequent complication, though most resolve without intervention. Question. When do you aspirate a seroma? Answer. Aspiration is performed only if the seroma is symptomatic, persistent, or infected, as unnecessary aspiration can introduce infection. Question. What is the risk of surgical site infection? Answer. The risk ranges from 1 to 5% in clean cases and can exceed 20% in contaminated situations. Question. How is an infected synthetic mesh managed? Answer. Management usually requires partial or complete mesh excision, as long-term antibiotics alone are rarely effective. Question. How is an infected biologic mesh managed? Answer. In many cases, infected biologic mesh can be managed with wound care and antibiotics, as it will eventually incorporate or resorb. Question. What is the rate of hernia recurrence? Answer. Recurrence ranges from 2 to 5% for small synthetic repairs, 10 to 20% for large or complex repairs, and may exceed 30% for biologic mesh in contaminated fields. Question. What causes recurrence? Answer. Recurrence may be due to technical errors, patient risk factors such as obesity, smoking, or chronic obstructive pulmonary disease, as well as infection. Question. What is chronic pain after hernia repair? Answer. Pain lasting more than 3 months post-operatively, often due to nerve entrapment or mesh-related inflammation. Question. How is chronic groin pain managed? Answer. First-line management includes nonsteroidal anti-inflammatory medications, neuropathic medications such as gabapentin, and physical therapy. Nerve blocks and, if needed, surgical neurectomy are considered in refractory cases. Question. What is a myxoma? Answer. A myxoma is a crumpled or buckled mesh that can cause pain, erosion, or hernia recurrence. Question. What is bowel obstruction? Answer. Bowel obstruction after hernia repair may result from adhesions, internal herniation around mesh, or recurrent hernia. Question. What is an enterocutaneous fistula? Answer. An enterocutaneous fistula is a connection between the bowel and the skin, often due to mesh erosion. Question. How is a mesenteric fistula managed? Answer. Management requires mesh removal, bowel resection, and frequently a temporary stoma. Question. What are activity restrictions after repair? Answer. Patients should avoid heavy lifting greater than 10 to 15 pounds for 4 to 6 weeks to allow mesh incorporation and fascial healing. Question. When can a patient drive? Answer. Driving may resume once narcotics are discontinued and the patient can perform emergency maneuvers without pain, typically after 2 to 3 weeks. Question. What is the role of an abdominal binder? Answer. Abdominal binders may be used post-operatively for comfort, support, and to reduce seroma formation, though the evidence for their benefit is mixed. Specific scenarios and controversies. Question. How is an umbilical hernia in an adult repaired? Answer. Umbilical hernias are usually repaired with mesh placement, either as a sublay or underlay, due to lower recurrence rates compared to primary repair. Question. How is a small epigastric hernia repaired? Answer. Small epigastric hernias under 1 to 2 centimeters may be repaired primarily, while larger defects require mesh reinforcement. Question. How is a Spigelian hernia repaired? Answer. Mesh repair, either open or laparoscopic, is almost always necessary due to high recurrence rates with primary repair. Question. What is a peristomal hernia? Answer. This is a hernia that develops adjacent to an intestinal stoma. Question. How is a peristomal hernia repaired? Answer. Options include relocating the stoma, suture repair, which has high recurrence, or mesh repair using the Sugar-Baker or keyhole techniques. Question. What is the Sugar-Baker technique? Answer. In this method, mesh is placed in an underlay position and the stoma limb is lateralized against the abdominal wall to prevent herniation. Question. What is a keyhole technique? Answer. The keyhole technique involves cutting a hole in the mesh for the stoma to pass through. It has higher recurrence rates than the Sugar-Baker technique due to mesh contraction around the stoma. Question. When is a hernia repair considered emergent? Answer. Hernia repair is emergent when there are signs of strangulation or perforation. Question. What is the approach to an emergent incarcerated hernia? Answer. Emergent cases require open exploration, assessment of bowel viability, resection of non-viable bowel, and usually primary repair without mesh due to contamination. Question. When can you use mesh in an emergent case? Answer. If the field is clean after bowel resection, biologic mesh may be used in healthy patients. Question. What is an awake hernia repair? Answer. Awake repair utilizes local anesthesia and sedation, suitable for high-risk patients who cannot tolerate general anesthesia. Question. What is the role of resorbable synthetic mesh? Answer. Resorbable synthetic mesh serves as a temporary bridge in contaminated fields, providing temporary strength while the body forms new fascia. It is resorbed over months. Question. What is the fascial closure rate? Answer. The fascial closure rate is the percentage of cases where the fascia can be reapproximated in the midline, a key goal in complex repairs. Question. What is the impact of not closing the fascia over an intraperitoneal onlay mesh? Answer. This may lead to a higher risk of seroma, bulging or pseudorecurrence, and possibly increased recurrence rates. Question. What is the 90-10 rule for transfascial sutures in intraperitoneal onlay mesh? Answer. This rule directs that sutures should pass 90% through the abdominal wall and 10% into the mesh, to avoid catching underlying structures. Question. What is the most common nerve injured in open anterior component separation? Answer. The intercostal nerves, which course between the internal oblique and transversus abdominis muscles, are most commonly injured. Question. What is a wound manager or negative pressure wound therapy system? Answer. These systems are used to manage open abdominal wounds or complex infections, facilitating controlled secondary healing. Question. What is the role of tincture of thyme? Answer. In infected fields, sometimes the optimal approach is to control sepsis, manage the wound open, and plan for definitive repair after 6 to 12 months. Question. How do you calculate mesh size? Answer. Measure the defect and add at least 3 to 5 centimeters of overlap in every direction. For a 5 cm defect, an 11 to 15 cm mesh is required. Question. What is the recurrence rate for primary suture repair of small umbilical hernias? Answer. The recurrence rate is approximately 5 to 10%. Question. What is the recurrence rate for mesh repair of incisional hernias? Answer. It ranges from 5 to 15%, depending on hernia size and patient factors. Question. What is the most common cause of early postoperative small bowel obstruction? Answer. Adhesions from surgery or internal herniation caused by mesh are the leading causes. Question. What is the coffee bean sign on computed tomography? Answer. This radiologic sign indicates a closed-loop bowel obstruction, where two adjacent, dilated loops of bowel resemble a coffee bean, which is a surgical emergency. Question. What is the role of computed tomography scan for postoperative fever? Answer. It is used to rule out intra-abdominal abscess, fluid collection, or missed bowel injury. Question. What is the management of a superficial surgical site infection? Answer. The standard treatment is to open the incision, allow drainage, pack the wound, and consider antibiotics if surrounding cellulitis is present. Question. What is the management of a deep surgical site infection with mesh? Answer. If synthetic mesh is exposed but not infected, aggressive wound care may salvage the mesh. If infected, mesh removal is usually required. Question. What is a bioburden? Answer. Bioburden refers to the degree of microbial contamination, which influences the type of mesh used in repair. Question. What is the difference between contaminated and dirty fields? Answer. Contaminated fields, Class 3, are open, fresh, accidental wounds, cases with gross gastrointestinal spillage, or entry into urinary or biliary tracts with infected materials. Dirty fields, Class 4, involve old traumatic wounds with devitalized tissue, established infection, or a perforated viscus. Question. What is the role of antibiotics in elective hernia repair? Answer. A single preoperative dose of a first-generation cephalosporin is standard for cases involving mesh. Question. How long are antibiotics continued? Answer. Antibiotics are generally continued for 24 hours postoperatively, as longer courses do not provide additional benefit. Question. What is the impact of chronic corticosteroid use on hernia repair? Answer. Chronic corticosteroid use increases the risk of infection, impairs healing, and raises recurrence rates. Question. What is the impact of chronic obstructive pulmonary disease on hernia repair? Answer. Chronic elevations in intra-abdominal pressure from coughing are a major risk factor for recurrence. Question. What is the most important determinant of long-term success? Answer. Optimizing the patient before surgery, by promoting weight loss, smoking cessation, and diabetes control, is the most critical predictor of long-term success. Question. What is the final take-home message for a resident? Answer. Ventral hernia repair is not simply about closing a defect. It requires careful patient selection, meticulous technique with tension-free closure and wide mesh overlap, and thoughtful mesh selection based on the clinical context. Ultimately, the best repair is the one that best fits the individual patient. Thank you for joining this comprehensive question and answer podcast on ventral wall hernias. If you enjoy the content, please subscribe to the channel and hit the notification bell to be the first in line for future episodes. It's the Everything Surgery Podcast. Dissect the extraordinary.